or removed from the agenda at any
Right.
time.
Mr. Chair, you may be chair of the county commissioners, but I'm the chair of this committee, so I'm calling it to order.
Okay, well, I was going to turn it over to you, so there we go.
No. I'm the chair, so I'm going to call this meeting to order. Thank you, Chair.
Be my guest.
Commissioner. This is Assemblywoman Dr. Robin Titus, the chair of the Lyon County Board of Health, and I am now calling this meeting to order. As was briefly stated, we are, let's see here. You're welcome to provide comments or any supporting materials for this meeting. You can send it to the county clerk at lyoncounty.org. Written public comments may also be mailed to Lyon County Manager's Office at 27 South Main. Public comment, Lyon County allows the following. If you're attending the virtual Zoom meeting, public comment may be provided by raising your hand. We'll pay attention. We can see all of you on the screen. This can occur in several ways, including by dialing *9 from your phone to raise your hand and request to speak for public comment. Then to unmute yourself, dial *6. County Commissioners meetings are this Board of Health meetings are open to public, and members of the public may attend in person, and the meetings are also virtual and public. Let's see, virtual but you may attend in person. Please to avoid meeting disruptions by cell phones on beepers or phones and beepers in silent mode. I don't know who has a beeper anymore, but if you do, put it in the silent mode or turn them off during the meeting. We can still hear those during these meetings. The board reserves the right to take a business out of order for the most efficient manner. And maybe some items may be combined. Restrictions on comments by the general public. Any such restrictions must be reasonable. That must be reasonable and may restrict the time, place, and manner of the comments, but may not restrict comments based upon viewpoint. So we'll now take the roll call.
Madam Chair, we have everybody online with the exception of Commissioner Jacobson. We do have the sheriff, yourself, and then 4 of the county commissioners. Commissioner Jacobson is the only commissioner who's absent.
So I do see Commissioner Keller, Commissioner Gray, and I see Commissioner Henderson and Commissioner Huckabee. Thank you. We'll now take the pledge of allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. At this time, I'll ask for public participation. No action will be taken on any item until it's properly agendized. I see no public in the room. Is there any public on Zoom that would like to have a comment? Seeing none, and if we don't call on you, you could go ahead and speak up, unmute yourself if you are there and I'm not seeing you. All right. So for possible action, we're going to review adoption of the agenda. Is there any concerns over the agenda? Hearing none. So first off, we're on item number 5 now. My comments, I appreciate all of you being here. It was exciting to see that after a 15-day shutdown to save the nation and a state shutdown, our governor has now released the emergency orders. So hopefully this state can get back into running and this county can move forward. And I just want to comment that everybody involved in this COVID pandemic, now endemic, really worked hard on it. And regardless of any political beliefs one way or the other, this really was about doing the right things for Lyon County citizens. So I want to thank everybody who was involved and keeping our county safe and the citizens safe. Having said that, we'll move on to the regular agenda. 6A for possible action, presentation on Nevada's NACO's public health coordinator position, seeking board input from Lyon County Board of Health on how this position may aid with local health priorities. Taylor Allison, Nevada NACO public health coordinator. Hello, Taylor. You have the floor.
Thank you. For the record, can you hear me okay? For the record, Taylor Allison, Nevada Association of Counties Public Health Coordinator. Thank you for having me today. I'll be very brief. Oh, this is great. So I just jumped on board with NACO in March of this year, not new to public health in Lyon County, though, long-term Lyon County resident. My family's here, and have worked in public health in the Quad Counties for about 12 years now. So excited to lean in, especially here, because this is my home. So the NACO board approved this roadmap for the position at the March NACO meeting to really help support counties navigate a path forward. Thank you, Dr. Titus, you kind of queued me up for this exact conversation. Where do we go from here? What appetite of public health makes sense for Lyon County? And how can I be of support to you all in having those conversations? And so my grant goes through June of 2023, and I hope to give each of the counties the biggest bang for your buck that you get with this grant in just surveying where we're at, developing formal proposals as appropriate, maybe pivot, restructure, build programs as needed or as desired. So just quickly, perspective, developing a baseline of public health. Public health is such a broad conversation. It can be environmental health, STD testing, clinical services, a lot of the pandemic preparedness work that's been done. So working with the counties to develop a baseline where we're at today in 2022. A lot of infrastructure was built during the pandemic, but it may not be sustainable. It's on different funding streams that may be going away, part-time COVID relief or one-time COVID relief funding. So working with the counties to determine what is our baseline in 2022, today's snapshot, and what is the goal to move forward. We have some tools in our toolbox to determine that baseline. For most local leaders, if you ask what is our baseline, it's that list of mandated services, you know, what is offered through assessments and otherwise through federal grants in our local communities. That may be extra, but the mandated services is like the baseline. What do we need to accomplish? And then these other tools, foundational public services, I do have a slide on that, and then state and local assessments. The reason I wanted to bring this up is if you ask a public health person compared to maybe a local leader, this is the like national best practice for minimum level of public health services if local health department infrastructure is in play, which is not the case for rural communities. But it doesn't mean these are things that each community may consider as foundational level service, that communicable disease control, chronic disease and injury prevention, environmental health, maternal child health, access to care. And then for the purposes of the assessment we're doing at NACO, we include behavioral health, because if you ask any local leader, and you all can speak to this too, what are the top needs? Mental health, access to care, those basic behavioral needs are there too. So in any of the work I'm doing through NACO, we're including behavioral health in that lens and working with the regional behavioral health coordinators to gather that information. State community needs assessment does have a Lyon County profile. The 2019 assessment is available to all of you. And then DPBH, the Division of Public and Behavioral Health, just contracted with UNR to update these assessments. They're leaning into counties that don't do their own assessments, so that Lyon County information would be available with that state profile by the end of this summer. Megan Kamwasi's office is leading that up, and I'm happy to help support in making sure that this community has access to that data. And then local community needs assessments, you have an agenda item on the Carson Tahoe one, but the not-for-profit hospitals do assessments every 3 years. Most of those are coming to the end of their cycle. And then the community coalitions have that substance use prevention, wellness data that's available. And then once you develop that baseline, what are the solutions? The Bipartisan Policy Center has a great toolkit, a pretty high level policy solutions that each community could tailor and pick and choose. They're broad enough where you could look at financing. I was out doing a presentation this week at the Rural Public Health Summit, and speaking to partnerships and community engagement is rural communities bailiwick. So there might not be a lot of gaps or policy solutions needed there, because that's what we do well. We rely on each other to accomplish those basic level public health services, but workforce gaps maybe where each community may lean in with the workforce challenges right now. So that tool is linked there in the slides. It's pretty comprehensive. And like I said, broad enough to where I think it could be tailored and help support policy solutions. And that's it. I just want to lean in that I may be reaching out to each of the members of the Board of Health just to gauge, your perspective on where we're at and where you'd like to see the community move forward based on your expertise and conversations with constituents. And really, if you need anything, I'm here. Happy to take any questions.
So thank you, Taylor. Any questions? I do have some, but I'll open it up to the other board members to start. So first, Taylor, thank you for taking that role. I think it was something that is very evident during this COVID pandemic that there was different needs in different counties. And so it'll be interesting to see, because you're representing all 17 counties, correct? So you're going to be able to talk to the Washoe County Health District and those folks, and then the Clark County, and then the different rural areas. I'm interested in line county profiles that you have on health needs assessment type of thing, community needs. I'll be fascinated to see what that 2019 looked like, and you would put it on the same template as the 2021 template, and then in recovery, because there were things we need in 2019 that we probably still need in 2022, but then it got all derailed during 2020 and 2021. The take home, I would say, is that we don't know that we're not going to have another of that 2021. So how do we then prepare now going forward for what we already needed in 2019, the new stuff that was there, and now this recovery process, not to be ignored all the other problems that we had, and it just got derailed. And I was just concerned, be interested to see if so much of that got worse, of the holes that we saw, or because we revved up healthcare in general, or just access or testing or whatever, that it actually will improve a little bit just because of our awareness. So that's good information to have. And thank you for coming on board and trying to tie this state a little bit together. And definitely we have similar needs, but sometimes unique needs. So anybody else, any other questions?
Not seeing any, ma'am.
All right, thank you very much.
Thank you.
We'll move on to 6B for possible action and presentation on Carson Tahoe Hospital's Community Health Needs Assessment, seeking board input on needs and priorities. And Amy Hines Sutherland, Dr. Amy Hines Sutherland will be the presenter. She's Director of Mission Integration and also has local ties.
Thank you. Thank you, Dr. Titus. Thank you for having me here today. This is Amy Hines Sutherland for the record, here on behalf of Carson Tahoe Health. And I'm here to talk about one of those regional needs assessments that Taylor mentioned in her presentation. So as a not-for-profit health system, Carson Tahoe Health does conduct a community health needs assessment every 3 years. This year in 2022, we're opening it up to a Quad County community health needs assessment. And we are working very intentionally with a regional coalition of agencies, not-for-profits, community organizations to ensure that we get a really good picture of what the community has decided is most important to them, what health needs they think are most important. And so we contracted a consulting agency, Crescendo. They're helping us facilitate this. And really, we've got two goals. Carson Tahoe really wanted to approach this with these two goals in mind. One, we want to establish a baseline, or a kind of a further baseline. We've got our prior assessments, but we know a lot has changed in the past couple of years. So we want to collect that data. We want to understand what community members are talking about and are saying is most important. We want to be intentional about the services we offer. So not what are we willing to offer, but what are people telling us they need and how can we adapt to meet those needs. And then the second goal is coalition building. So in the past, we have definitely gotten community input on how we do this needs assessment, but this time we're really trying to connect with as many of the counties as possible, and leaders from the counties, and social service providers from the counties, law enforcement, teachers, educators, really as many folks as we can. And the goal there is that through this process, we're hoping that Carson Telehealth becomes more integrated into the response systems that are already in place across the Quad County region. So those are our goals, and then methods. So this is ongoing, and this is where I would love feedback from all of you on how we can best get that Lyon County voice. So our firm is helping us with key stakeholder interviews. So I think a number of you have been invited to those, but if there are others in the room that would like to participate, please, by all means, reach out. We'll also host focus groups. We will also have, those will launch in the coming month. We'll have a email survey, but that will also be printed and made available at various sites for people who don't want to access that survey via email. There will be an access audit, kind of like a secret shopper process to understand what it's like to be a consumer trying to access our outpatient services. And when I say our, I mean our Quad County services, not just Carson Tahoe's. And they'll also do phone surveys. And then they do this whole other secondary data analysis for us. So they pull all of the domains and measures that they pull nationally when they work with folks, but then we also did a really deep dive into what those domains and measures look like and said, hey, add this for our county, add this for Nevada, add this because this matters to us and we know this really matters here. So I think it'll be a pretty robust product and something that'll really help guide us. But all of that really depends on that input, right? So thank you, and just here to answer questions about it and also just get insight into what you think might be the best way to get that Lyon County voice into this project.
All right, thank you. Any questions? Any hands raised?
Nope.
Manager Page, nothing, can't see anything. So certainly, just because there's no questions now, doesn't mean we won't have questions later. I do appreciate you kind of going over this, and it does kind of dovetail in what Taylor was bringing up also, and that communications, and we all sit on a board that will be coming up here later. Actually, there's 4 of us that are in this room today that are on that board, so certainly can continue that conversation. And as you share some of this information that we have, it'll be interesting to see what really we need moving forward here. And I think that's really the goal here, is to make sure we can move forward together. And kind of consolidate some of these efforts. As we know, personnel is very lacking, so it helps to be not reinventing the wheel all the time. So thank you.
And actually on that, I just wanted to add, since you brought that up, part of that needs assessment process at the end of that data gathering is a needs prioritization process. And so we hope to have that wrapped up in September. And so that's kind of nice too, because it helps us understand, well, yes, we know we need these 50 things, but the community is ready to act on these 5. And so, using that momentum of what the community is talking about and saying is most important to them, I think that'll help us with that. Where do we go now that it's 2022 and we know what has happened since 2019? And then the next phase of this, I want to encourage you all to reach out if you have additional questions and participate as possible. Because once we have that data in, the next phase is a 5-month implementation strategy phase. And so that's where it's really important that we've built the coalition as we go through. And I realize there's a lot of other surveys going on right now, a lot of other assessments, right? We're spread thin even in the data gathering phase, but to the extent we can all work on these projects together, I think that implementation strategy phase will help organize us towards solving this.
So I appreciate that, because one of the issues is if we're all gathering data, but we're not sharing that data, I mean, it doesn't help us much. So making sure that the data that's collected is shared, and that we're not all trying to collect the same data either. So that, because again, as you mentioned, there's not enough folks out there. So trying to coordinate all that and using the University of Nevada's Reno folks that do have those that access would be important. But also when you talk about priorities and needs assessments, there's things that as you mentioned, maybe we get 50 suggestions, but really what's the 5 months plan? What can we tackle tomorrow? What can we tackle in a couple of weeks? And what's our, say, 5-year, 10-year plans? And so I think it's important that we kind of prioritize it that way also. Thank you.
Thank you.
All right, seeing no other questions or comments, we're going to move on to 6C. for presentation only, presentation on Mental Health Awareness Month and available local behavioral health services. Shayla Holmes will be presenting, and I know we have some other folks after that.
Do you have a slide for this one?
I should. I hope you.
E D A.
Have it, Aaron? Or do you want me to? I can.
Hang on.
I got it. Are you sure?
I probably have it, just didn't see.
I just forwarded it to you, Jeff.
Okay. No, that was the wrong. That
Oh,
was
okay.
what you sent me earlier.
Oh.
All right, try this again. Sorry. Technology challenge here.
Keeping me on your toes. We're just building the suspense. Yeah. Yeah. Of which I can. It just won't be as exciting.
Come on. Why isn't it letting me do this?
It's so interesting. It's disappearing into the abyss.
Do you have it on a thumb drive? Okay, that's fine. Yeah, try that.
There we go. All right. righty, thank you for your patience with us as we got that up and going. Shayla Holmes, Director, Lyon County Human Services, for the record. This month is May, and May we recognize mental health awareness. I realize it is near the end of May, but I thought this presentation would be a great pairing for the Board of Health in regards to some conversations that we're having during this meeting. And part of why we bring together this group of partners that are going to be presenting to you today is to show, as much as we have this resource scarce mentality, we are also rich in resources and providers within our area. So when a group of folks come together and a group of providers come together with a common focus to serve a community, we are able to make a lot happen. So I want to make sure that those partners and providers that are out here doing hard work in Lyon County have an opportunity to present to you all the hard work that they do in the community that they reach and the services that they offer. So just to prime the conversation as far as behavioral health trends, of course, we all know what the COVID-19 pandemic has done to our communities at a glance in regards to the isolation, the anxiety, the increased stress, and an estimate of 50% of all Americans are diagnosed with a mental illness or disorder at some point in time within their lifetime. And the pandemic has exacerbated that and really brought that to light. The other thing to really keep in mind is that mental illness, such as depression, is the third most common cause of hospitalization in the United States for those aged 18 to 44. And the data for our area aligns with that. The mental health is health in regards to what impacts that has on the individual, their body, and what types of services that they need. And the other thing to consider is that adults living with serious mental illness die on average 25 years earlier than others. So I think it's really important to prioritize behavioral health when we're talking about health in general and how we can continue to integrate that into our priorities. And with that, I want to introduce Michelle Sandoval. I gave her a promotion in our agenda. I inappropriately titled her the Director of Rural Clinics. She is the Program Coordinator of Rural Clinics for the state. She is on Zoom with us this morning, and she will go ahead and take over at this point in time.
Thank you, Shayla.
Good morning, Michelle Sandoval, for the record. Thank you for correcting that, Shayla. I appreciate it. Yes, our agency director is Ellen Richardson Adams, and she's out of Las Vegas. So with that, Shayla, you did a great job of introducing that. And of course, I love May, Mental Health Month. I'm a licensed clinical social worker. I've worked for rural clinics and rural communities through DCFS for over 20 years. So my passion is rural Nevada. And I'm always happy to speak about mental health services in our areas. And as Shayla said, it's, there is a sparsity, there's always more need, but we are fortunate in our rural communities that we do have some services. And I think we all partner together very well to try to get these communities' mental health needs met efficiently, quickly, effectively. And one of my biggest things is bringing quality services to rural areas, because it's, just because people don't live in an urban area doesn't mean that they should sacrifice the quality of care that they get. So it's really that quality that I think that we're bringing to our rural communities with that attention. So for rural clinics, I'll just give a brief overview. These are the services that we provide. And of course, we have several clinics in the Lyon County area. We do individual, group, and family therapy. We have our medication management clinic, case management for those consumers who really need that extra support and help, even with things like basic needs. We offer rehabilitative mental health, and that's really for those consumers who need that enhanced partnership and wellness so that they can live their best life. We have residential support, so we do have housing available in our rural communities for those in need. We have a psychology team, and they are able to do testing on youth and adults. We have mobile outreach and safety teams in some of our rural communities. We offer peer support services, behavioral health screenings, and then we also have our 2 crisis response and stabilization teams, one for youth and one for adults. So I wanted to explain a little bit. Shayla asked me, I think everyone's familiar with rural clinics. One of the things that we have really worked on over the last 2 years is community collaboration and coordination of care. And you can see these are our 3 specialty programs. So this is our Children's Mobile Crisis Response Team, which I'll talk about in a second. Then the middle one is our emergency room consultation and screening team. And then we have our immediate mental health care team for adults. So I want to focus real quick on the emergency room consult and screening team. So this is one of the things I think Rural Clinics has really enhanced over the last 2 years. So before we had this team, any consumer who walked into one of our rural clinics to seek mental health services, depending on their level of need, if they were in crisis, if they were, okay to wait for an appointment, we were expected to have someone there at the clinic who could see that person immediately. And what ended up happening is we were pulling nurses out of doctor's appointments. We were pulling clinicians out of scheduled outpatient therapy appointments to be able to see these consumers who were walking in. And so it was kind of a disruption in services. So what we did is we came up with a team specifically that can see people that walk into any of our rural clinics immediately. So we have an on-call clinician every day. We have what's called a scheduled clinician every day. And so we're seeing people very quickly. And that screening allows us to work with that consumer to see the urgency of their needs, what their treatment needs are. And then we have a case manager on this screening team that's able to work with other community providers, specialties across the state. That's one of the things that COVID gave us for our rural communities that I think is amazing, is access to some really specialized treatment and care for mental health via telehealth. So then we're really working with community providers and the consumer to see what the best referral for them is, and that's not necessarily rural clinics. So we partner very well with Community Chest and with Rural Nevada Counseling, with NAMI, with our peer supports, and it's really about seeing what that consumer needs. And our rural clinics we kind of see as that safety net, as catching those consumers who are indigent or uninsured or underinsured. So I think that's been amazing. We're seeing people a lot quicker. We're getting them connected to services quicker through this screening team. There was some hiccups with it because some consumers walking into our rural clinics, like in Yerington, for example, they were wanting to be seen in person by someone for that screening. And so it took a little while to adapt, but I think overall the rural communities are finding that this is getting the consumer's needs served quicker and more efficiently. So. And then we have, then we have our mobile crisis response team for youth. This is available in all of our rural communities. Your families and youth are connected to a clinician within about 15 minutes to begin the process of trying to stabilize a mental health crisis, prevent hospitalization, or assist with hospitalization for safety if needed. Right now, our hospital diversion rate for children's mobile crisis is around 84%, which means that 84% of youth and families that would have presented in our rural emergency rooms, we were able to stabilize them and get them services in their home communities. And then the immediate mental health care team functions very similar to the mobile crisis team, but it's for adults. Hospital diversion rate there is running about 94%. So again, adults who call into the care team, they're able to meet with a clinician within about 15 minutes, and we're able to stabilize symptoms and prevent hospitalization about 94% of the time. Another cool thing about about the care team and mobile crisis is we also work with rural consumers who are discharging from any type of hospitalization back into their rural community. So the hospital discharge planners will call one of these teams, and the clinician hopefully meets with the consumer before their discharge so that we have that connection, and we can walk with them back into the rural community and get them hooked up with services. But even if they can't, then we're contacting them, the consumer, as soon as possible after their hospital discharge. And we're seeing about an 80% higher follow-up rate with this warm handoff from hospital discharge back into our rural communities. I talked really fast. Any questions?
Anybody have any questions? I'll have some at the end. I'll wait until the whole presentation. Thank you.
Next, I'd like to introduce Laura Yanas. She's the Executive Director for NAMI Western Nevada. And I believe she is also on Zoom.
Yes, thank you very much. So today I want to talk a little bit about NAMI programs. We actually offer a variety of programs for peer education and family support and education within the community. Given that we have, a limited amount of time, I wanted to focus in on two programs that we primarily, or that are immediately available to people when they're in need of mental health support. One is the Nevada Warm Line, which is ran by NAMI Western Nevada. It is a statewide program. However, we find about 35 to 40% of all of our calls are based in the rurals. And unfortunately, I don't have that broken down by county. I just have it by region. The Warm Line is staffed by individuals who themselves are living with mental illness and are in recovery, and they provide support based on their shared lived experience with mental health. We know that providing peer support is within best practices of care. What's unique about the Nevada Warm Line is that we are an inbound outbound service. So for example, we actually take referrals in and will reach out to somebody to offer them support. Where we see a lot of our referrals are coming from is from hospitals. Adult Protective Services uses it as a way to connect seniors that are impacted with mental illness to social contact, especially when they're socially isolated. The Warm Line actually started in 2018, November of 2018. And prior to COVID, we had about 220 calls per month. At the peak of COVID, we went up to about 1,300 calls per month and are now stabilized at between 1,100 to 1,200 calls per month. And these are both inbound and outbound. Part of what was also developed through this program, which is called the Nevada Caring Contacts Program, is a suicide prevention, hospital prevention program. And this is actually working with an individual's clinician or with a hospital. They're referred into the program. They get intensive support from us, which is, 7 days a week contact, and then it slowly drops down. It's about a 90-day program. And we found great results in that. On the adult side, out of 56 people we had enrolled in the program in the first 6 months, 48 engaged with the program. And we had one individual who was hospitalized and one individual who made a suicide attempt. So that means that we had a rather large impact on supporting the people in that program to stay out of the hospital and to remain safe. The other program I want to talk about is actually one that just launched. It launched last Monday. We were really excited to get it started and wanted to get it started before school let out. And that's the Nevada Teen Peer Support Text Line. And this is for individuals who are 14 to 24. Although we do have some that are younger involved in the program. Within the first week, the program received 1,400 texts. So there was definitely an interest in the program and a lot of need for the program. This program, much like the Warm Line, and it's actually based on the Warm Line, and there's currently only one other teen peer support line for mental health in the nation, and that's ran out of NAMI, Maine. So individuals who are 18 to 28 who themselves have lived with a mental illness during their teens or early 20s staff the Warm Line. They are also in recovery, or the text line, excuse me. And they provide that one-on-one peer support. How are you doing? I know it's hard. I've been there too. Let's talk about, if it's what coping strategies do you have? It's encouraging them to, if they are in treatment, to engage and to speak with their clinician. It's just being that peer support that is there to listen. And it's been a very interesting process to develop the line. It was actually developed by transition age young adults so that it specifically met the need of that population. And we're really excited to see where it goes. Both of these lines are available to Lyon County residents. And I know we work with Michelle. I know we work with the MOST team and the FAST team, really trying to get the word out. We have little cards that we distribute and that our partner organizations help us get out into the community, just so people can put it in their wallet. And maybe they don't call that first day or text us that first day, but at least it's there as a resource. One thing about the Nevada Warm Line that I neglected to mention is that in July, that line will be going 24 hours a day. So that will be even more of a resource. Currently, the teen text line is from 12 p.m. to 10 p.m. Monday through, or 7 days a week. The nice part about both of our lines is that they are also open on holidays. There's 365 days a year. And thank you.
Thank you. Shayla, any additional?
We have two more. The next one is Rural Nevada Counseling, and I believe we have Mandy Reese and Dr. Juanita Chapman on Zoom to present their services.
You hear me?
Are you ready?
Can you hear us now? Are you able to hear us?
Yes, we can hear you.
Okay, all right. So can we actually go back to the last slide, please?
Sure.
Perfect, thank you. So Rural Nevada Counseling is an integrated behavioral health care center. We've been servicing the people of Lyon County for 25 years. We have offices in Yerington, Silver Springs, Dayton, and Fernley. Next slide. Okay, thank you. Your pathway to recovery. We help people reach their behavioral health goals from a whole person approach. This means looking at mental health and substance related needs while considering physical and environmental factors as well. Rural Nevada Counseling staff work with clients to help identify the areas where they need the most help. We provide the support clients need to address and resolve their concerns. We have real life experience professional trainings and access to resources that will help accomplish this from recovery oriented stance. Social, emotional, spiritual, intellectual, physical, environmental, and occupational are things that areas that we work on. SAMHSA, we are SAMHSA recovery principle driven, and that's what help guides us.
We've already told you that we served Lyon County, and we also have two supportive houses, one in Silver Springs for males and one in Dayton for females. So these are some of the things that we do. We provide drug and alcohol counseling, we provide mental health counseling, medicated assisted treatment, crisis intervention, peer support, transportation, anger management, wellness and prevention, and telehealth, psychiatry, medication management.
Care coordination, transitional housing, case management, basic skills training, psychosocial rehabilitation, ambulatory detox, National Alliance of Mental Illness support groups, and we have a 24-hour crisis call line and peer line.
We currently employ a wide breadth of seasoned behavioral health professionals, including SID, MFTs, LCADCs, LADCs, CADCs, and CADCIs, as well as certified PSR and BST staff. We have many licensed professionals with educational backgrounds in mental health, social work, and human services disciplines. Our medical director is a licensed MD who is also assisted treatment, and she's out of Carson City. We are a 501c3 nonprofit agency. Our board of directors consists of 6 community members. We have a staff of 58, which is kind of fluctuating a little bit more probably at the current time. We accept Medicaid, and we also accept sliding fee scales, and we don't turn people away if they are not able to pay.
The CCBHC program. The purpose of this program is to help transform community behavioral health systems and provide comprehensive, integrated, coordinated, and person-centered behavioral health care systems to improve access to community-based mental health and substance use disorder treatment and support. This is including the 24/7 crisis phone lines to anyone in the area who needs them, regardless of their ability to pay or place of residency. This includes those with serious mental illnesses, substance use disorders, including opiate use disorders, children and adolescents with serious emotional disturbance, individuals with co-occurring mental health and substance use disorders, and individuals experiencing mental health or substance use related crisis.
The scope of our services. We have crisis mental health services, which includes a 24-hour mobile crisis team, emergency crisis intervention services, and crisis stabilization. We do screenings, assessments, and diagnosis, including risk assessments. We are patient-centered when we offer patient-centered treatment planning, including risk assessments and crisis planning. We offer outpatient mental health and substance use services. Our outpatient clinic primary care screening and monitoring of key health indicators and health risks, such as BMI, blood pressure, tobacco use, HIV, and viral hepatitis. We also have targeted case management, psychiatric rehabilitation services, peer support and counselor services and family support, and intensive community-based mental health care for members of the armed forces and veterans.
RNC partners with SAPTA licensed providers for alcohol and drug and co-occurring disorder treatment in Lyon County, as well as being duly licensed as an assessment center. RNC work closely with the justice system, including justice court, district courts, Lyon County courts, as we have members of the FAST team that go into the jail out in Urington. And then we also work with the Division of Public Safety, Parole and Probation, and also the Adult Drug Court Program. We work with clients that need medicated assisted treatment court programs and mental health court programs. RNC maintains a close relationship with the community agencies such as Lyon County Human Services, Healthy Community Coalitions, rural clinics, and first responders.
And that is it.
Yeah, it is.
Thank you, Mandy and Dr. Chapman. Next, our last community partner is going to present is Amy Rea with Community Chest.
Hello, thank you for inviting me to present today. My name is Amy Rea. I'm the clinical director at Community Chest. I'm excited to be here and tell you a little bit about us. These are all our phone numbers, our general line, of course. Our mental health crisis line, this would be, if this is a 24-hour line, in case you have someone that's in crisis as far as like suicidal or self-harming and need someone to talk to. We do a screening through there, and then we make appropriate connections, or we can call a well check. There's quite a few things we do through that line. Our domestic violence / sexual assault crisis line, we have advocates who will come not right onto the scene, but they work along with the police officers. Or if it's just someone that is in crisis and they need someone to talk to, they need to make a safety plan, they want someone to come along with them to do a TPO, or just a bunch of different services. They can call that crisis line and get services. And then we do take in walk-ins. So if someone is in crisis and they need to walk in, of course, we are Monday through Friday, 9 to 5. We do have community health workers who are trained to do an assessment. We can keep them We are we have enough clinicians that they could sit and wait with them while a clinician ends with the client and meets with them and does that assessment. And our referral form is on there too. You don't have to write it down. You can just look on our website and it's easy to find. Okay, so I just put everything on here just to keep me on here. So probably this will blind you, but I understand what it means. So for adults, we have substance abuse counseling. We work with the courts and we provide all court reports that need to be done. We also can, if someone comes in and they just want substance abuse counseling, of course, we provide that. But the majority of our substance abuse counseling is done through the courts. Mental health counseling, of course, we provide all the evaluations necessary for courts. We have free counseling for all victims of crime through multiple, like we right now currently have, I believe, just about every victim of crime grant available to us besides the one that's for marriage license, because we are not a standalone domestic violence agency. We're part of a larger agency that provides many wraparound services, but we have all those grants for victims of crime. So that is our, don't go on. That is our main source of funding. And we do have a sliding scale fee. We don't turn anyone away. Our clinicians are all certified disaster mental health response specialists. We've gone through a lengthy program. It happened right after the pandemic began. So we've been through quite a few that was a long program that had quite a few modules in it that taught us different ways to work with children, families, and different groups to work through the trauma of a shared national disaster. So that is a great resource that we have. And we are currently working on forming a dialectical behavioral team. It takes several years to accomplish. So we're very excited about that. And that will help us with the level of psychosis that we have in Lyon County. Some other issues as well as eating disorders and some other things, but dialectical behavior, having a dialectical behavioral team in the rurals is kind of unheard of. So we're very excited about that. As far as youth goes, we also offer the same type of things, substance abuse counseling, mental health counseling, but we have a special program that we work with juvenile probation and Lyon County. It's a shared program called multidimensional family therapy. The kiddos and the families are referred through Lyon County. Lyon County does a screening with them. And if they hit certain criteria, they come to us. Either way, they come to us and they're provided services. But if they are, if they fit the right criteria, they go into this specific program that is for the entire family. It's not just we include counselors, teachers, rabbis, pastors, everyone that might be in that family's life, and try to create a way for the family to heal on multiple levels. So you might end up seeing the parents going to drug and alcohol counseling, and the kids, us talking with the parents or the teachers. And basically it's a very holistic way of helping the family. So this is, I feel, has been a very successful program. I hope that we get to continue it in the future. Again, we do court-ordered evaluations for kiddos, the juvenile probation that we work with, and we do that at no cost for families. And then we have extensive training in evidence-based trauma-focused modalities for children. We also do filial therapy, which is for small children, like 3 to 6 years old, who have been through sexual trauma, domestic violence. And it's filial therapy is a therapy that is for training the parent to work with the child, because you can't do therapy with the 3-year-old. You just can't. Play therapy you can watch, but this is a much faster way to be working with the parent to help the parent learn to look for different signs, how to respond, how to cope, because a lot of times the parents are suffering as much or more than the child, and they need that support, and they need to know how to help their child in the long run. So filial therapy has been excellent for us, working for those small children. And then we also use experiential play therapy. So in a nutshell, we have 8 mental health clinicians, five of which are duly licensed in substance abuse counseling. We have 4 sexual assault and domestic violence advocates. If our grants go through, we'll be adding another one for Silver Springs. We have several community health workers available for walk-in clients and follow-up services. We have safe school professionals embedded in the schools who are there for able to offer groups, but they're also looking for that higher acuity that might be needing to pass on to our clinicians. And then we have offices in Burnley, Dayton, Yerington. Where am I missing? Oh yes, we're hoping to open another one in Silver Springs. So, and we provide through telehealth as well. So that's pretty much us in a nutshell. I think I had, we do work with the mobile crisis and care teams. We kind of think of it for us, we kind of think of it as like a second step to like, so they are out they're out in the field. If they can send someone to us, then we can be that next bridge to keep them out of the emergency room, because we do have people that are trained to work with suicidal clients where we're seeing them like 2 or 3 times a week. And then the next week we're seeing them maybe 2 times. We're making those contacts. We're working with the warm lines. The warm lines calling them and checking in on them. They're calling the warm line. So what we're doing is when someone's suicidal or someone has those suicidal thoughts, they're looking for connection. They're looking for networking. They're looking for people that care. And the more people we add to that, the more that person starts to say, oh, wait a second, there is a reason to be here. I'm not alone in this world. And so we're adding people to that whole network for them. And within 2 to 3 weeks, you start to see a huge shift in the way that they're looking at the world. So that's what we're trying to do in that pattern. And then the other thing that we do that I didn't add to that is that we have a robust internship, and I think it's really important to hire mental health clinicians in the rurals in Lyon County so that we don't lose our clinicians, because that is the most difficult thing I've found in the time that I've been a clinical director. So my push is always to hire someone that lives in our area, and then to bring in interns that we are teaching about the area, so that they get excited about working for their own community and stay. So that's the other program that I'm pretty proud of. That's kind of it's part of mental health services in a big way, because we want people that come in and are like, this is my community, I want to serve it. So that's the last thing I have to say. Thanks for having me.
Excellent. Thank you. Shayla, back to you.
Yeah, I just want to wrap it up with sharing what Lyon County Human Services has to offer. We are a collaborative effort, as you've heard, with many of these partners that presented to you today. Many of those partnerships are through the Forensic Assessment Services Triage Team. It's a mouthful, but the FAST team that helps with reentry from the jail. Our Mobile Outreach Services Team, which is a partnership with the Lyon County Sheriff's Department, as well as Lyon County Human Services. Our system of care is that program that Amy had touched on in regards to how we get children and families into the multidimensional family therapy. And then we also have Parent Project and Active Parenting. So parenting classes is probably that low-level intervention or prevention piece in how we help parents really take ownership in helping youth with those behaviors before they get to that next level. We also have Healthy Ideas, which is an evidence-based program that our senior services case management team implements, which it targets individuals over the age of 55 with depression and isolation symptoms and gives them tools to be able to manage that at home and within their own community and avoiding that higher level of treatment. We also have Powerful Tools for Caregivers, which are classes for caregivers providing care to anyone of any age with any diagnosis. It started as a developmental disability program and has since expanded to include caregivers of elderly, caregivers of those with behavioral health issues, really any scope of caregiving, and it is evidence-based as well, and our staff are trained to be able to offer those courses. So with that, we'd like to open it up to any questions that y'all may have.
Thank you all. Thank you all. So I'll start with taking questions from members of the board. It's a lot of information that was just given. All right, well, I've been taking notes and I have a lot of questions. So is there anybody who's raised a hand? Did I miss anybody, Jeff, before I jump in?
No, ma'am.
Great, thank you. So thank you all for the presentations and thank you all for what you're doing. A lot of great information, but I have some concerns and just observations, want to know how this is being worked out. I'm concerned there's way too many silos here, that I, had an office practice for 38 years, didn't know some of the availabilities of where to go. So my questions are, the new text line number that's out there. There's a lot of phone numbers coming down the pipe. Didn't hear anything today about the new 988 number that's going to be out there. We still have that 211 number that's supposed to be the wrong no door. And so now we have all these other numbers. And although teenagers text, it's only from noon till 10 p.m. And suddenly does that automatically then go to the new 988 number if you don't know that it only goes from noon to 10? And now you're in crisis and you're texting and suddenly it shuts off and you get no response. You think you're being ignored. The emotional teenager suddenly falls apart. And then what they do? So I have concerns about that. So does anybody want to address all these numbers?
I can, if it's okay with you, Shayla. So with the teen text line number, we actually work in close partnership with Crisis Support Services of Nevada. If somebody was to text in when we weren't open, they actually get a text reminding them of when our hours of operation are and giving them the Crisis Support Services of Nevada if they're in crisis. I think there are a lot of numbers and it can get kind of confusing. I think what we've done is tried to do a community education and really build collaborative partnerships that utilize MOUs to make sure we're not siloing our service or duplicating efforts. So that's what we've done on our part to try to make that more integrated into other services, which is part of our goal, is to not have it just be this standalone that's offering a number, but that is really being a community partner.
Thank you for that. And so also then along the same lines of my question in silos, are you going into medical staff offices? Are you doing a presentation as a group like what we just heard on availability? Because I have concerns about when we see somebody in the ER or when in the office and they're in crisis, where do they get referred? More than just that warm hand. I think warm handles are the new key term, and what we're using them a lot about warm handoffs, but where's the information? I would suggest that Shayla or statewide, maybe get something laminated that every single provider out there has a card. And I have one from when I checked actually a couple months ago, but it was done, I think, in the 90s, and all the services that we had, which are so different than now. And so going forward, if we could have, maybe something that we really focus on is forming one laminated page that every single provider, every police officer, every EMS person has to say, hey, here's something that might help. Here's all these options here, because I'm hearing a lot of services that frankly, a couple of them new to me today. And I sit on the interim healthcare committee. I hear this stuff all the time, but still I'm hearing some new stuff that I didn't realize was out there. So perhaps redoing our services in Lyon County, but more than that, the state services, something laminated that you get to every med staff, you get to every law enforcement officer, they have them in the car. And cards are great, but it's just your card as opposed to all the other services out there. And the other thing I had a question on safe school professionals. Are they identified in every school, or are they just somebody like the sheriffs, the marshals that fly on the airplanes and you don't know who those folks are, but they're there? Are these safe school professionals in every school? Do all the providers or say the teachers know they're in the schools, and does every school have one?
Amy, do you want to take the safe schools professionals, and then I would like to touch on the task force and some projects we have at hand as far as the silos and the communication.
Sure, absolutely. Yes, the safe school professionals are well known in the schools, that counselors in the schools work hand in hand with them. So yeah, they are very well known in each of the schools. And then they work under one licensed clinician. And they work not only with us, but also with Healthy Communities Coalition. And they all have their own program that they work that's well established. So yes, they've worked in the schools for quite a while, and they are very, very well known. And I'm super glad to see Jessica pop up, because I was like, oh, I hope Jessica's here because she can talk to how we do coordinate with the numbers and all of that.
So a follow-up on that, thanks Amy for that. Do all schools in Lyon County have a safe school professional, or is it just the junior highs? Is it just the high schools, every elementary school? I was just wondering what the coverage is.
All of the schools.
All right, thank you. And they have to have some level of training to be that. Is there a certificate that they have, a license that they have?
So they all are, my understanding, they're all bachelor's level at this point, or they are clinicians. And they are supervised, if they are not clinicians, they're supervised by clinicians. And they do have to have certain trainings to be able to do that. And they all, each depending on their level of training, they can offer different services. So some of them can offer psychoed groups. Some of them can, if they're clinicians, then they can offer the one-on-one counseling. So we do have those meetings where we meet with them. We talk about the clients. We do consultations to make sure that those kiddos are getting with the right level of clinician or counselor who can help them. So yeah, they also have like constant trainings that they're getting through Healthy Community Coalition and also through Community Chest.
Great, thank you. I would be remiss if we just didn't point out the events that happened in Texas, and it just brings up more parents are reaching out to me, concerns about quote unquote, what are we doing here to keep our kids safe? And just offering them, hey, we do have this installed, at least some reaching out to families and especially the students. So anybody else have any questions?
I just had a quick comment, Jessica Flett-Abris for the record. So you spoke about the hospitals and getting this information to the hospitals. And we've been creating a behavioral health binder actually for the hospitals. 3 binders will go to each hospital for the CEO, the emergency room, and the social worker. But they have all the flyers that we're discussing today, because I saw the same issue, Dr. Titus, is like, how do we get that information to the families when they need it?
Great, thank you. Hopefully we can get like the Cliff version of that, Cliff Note version into maybe sheriff's departments and, dispatchers even. And I don't know, do you work with our sheriff is sitting here and Sheriff Honeywell, can you address maybe what the dispatchers are doing? Do they have some of this access?
Frank Honeywell for the record. I know that we worked with Human Services going clear back to the Edry days. And we did come up with a laminated card that had all those resource numbers on it. Shayla and I talked about this before. Has it been updated? Obviously today I learned, just like Dr. Titus said, a couple other resources that I wasn't aware of. And I think we're doing a pretty phenomenal job on the fast side, the most side. But I do think we're lacking on some of those resource connection availability to the people that are, my guys and gals are the frontline people in 90% of this. And I think we need to do a little bit better job of updating that. So the answer to your question is, our dispatchers go through emergency dispatch training stuff, but I'm not so sure they have access to this information because it's kind of a different concept. And so I think it would be a good thing if we got together and we came up with an updated card. You remember the old green one that we had?
Yeah, we've updated it. So that has been updated with recent contacts. We changed it to not be name specific and to be position specific with the same continuity, like phone number that will always be there, whether the individual has changed position or not. And then we recently issued a juvenile card to go hand in hand with that adult card, since it gets to be a lot. So we did go around, Chief Smith and myself went around to your squad meetings and presented the juvenile card with the different child mobile crisis and some of those other contacts that are on there. We absolutely can, I would love to meet and discuss on how we can make that fluid for dispatch and then continue to make it fluid and less siloed for the other programs as new things come out. The other thing that I did just want to touch on is we do have our Lyon County Public and Behavioral Health Task Force, of which all of these folks participate in addition to other providers and other community partners, where we ensure that this information is being shared and we discuss issues such as these silos. So one thing that Jessica and I have been working on, and we worked on our last task force meeting with the school district, is our suicide protocol and putting together what the Columbia suicide screen looks like. And then on the back side, triaging which one of these programs and phone number correlates to which level you're at, whether you're yellow, red, or green, and what that looks like. And we're working to get that laminated and distributed to all of our partners, whether you're clinical or whether you're just a community service provider. So that way, when folks are talking suicide or having those conversations, our frontline staff are confident and comfortable knowing, oh, flip it over, this is who I need to contact when they said XYZ. So all things in the work, but I appreciate the feedback and the information, so that way we can continue to work on those silos and how we continue to educate and make it more fluid.
Excellent, thank you. Anybody, any questions now in the minds of anybody, all members?
Madam Chair, Ms. Sandoval has her hand up.
Great.
Thank you, Michelle Sandoval, for the record. I just wanted to touch on what Dr. Titus said about no one mentioning 988. And so as a member of the 988 Planning Committee, I just want to say that I think the vision of where Nevada wants to be with our crisis response system for mental health in 988 in the next 5 years is phenomenal. It's going to take us time to build that. And I think these silos that we're talking about right now, that's exactly what we're looking to eliminate with 988. And I just encourage everyone, I know Shayla has been a great part of 988 planning and trying to get in there and bring in Lyon County into that. And I just encourage Lyon County to, as 988 rolls out, to come to the table and really let your needs as a community be known, so that 988 has a way to really tap into these resources, these amazing resources in Lyon County. So it's going to take all of us coming together, but I think the vision's amazing.
And not to speak, maybe Shayla is going to talk about this, but I think she did meet with Rochelle in the last couple of weeks. And I think there's concerns about them and their bandwidth. So I'm just going to say that to be the person in the room.
I appreciate that, Jessica. So I did meet with Crisis Support Services in Nevada in regards to the 988 rollout and local integration and what that could look like. At this point in time, Crisis Support Services of Nevada is going to rely on their existing system and their existing provider contacts. So at our next task force meeting, we're going to ensure that all of our local providers are within open beds and have the information necessary, because Crisis Support Services will be launching with only utilizing open beds and Michelle's care team. So I also met with Michelle after that Crisis Support Services meeting and made sure that Michelle's case managers and our local Lyon County Human Services are well connected and can serve as that bridge, because I certainly do have concerns when individuals from Lyon County call in regards to how their basic needs are being met and getting referred back into the community and these local community resources. So working closely with Michelle to ensure that the state crisis support response is aware and referring back into Lyon County, and then we'll continue to be the voice to push how we either better open beds or potentially move into a different operating system to ensure that all of these services are available to those first dispatchers, so folks have to call one number and get what they need, as opposed to being passed around to different service providers until they get their needs met.
Right. So I'm on Old Doc. I've done this a long time. And so we heard about 211 way back when, and that was supposed to solve all these problems. You were supposed to call 211 and then every community would have that referral, but then it didn't get updated. You know, what if you called 211 and you lived, say, in Lyon County versus if you lived in Esmeralda County versus if you lived in Ely, et cetera, or just out there. So hopefully this new system will be able to handle it and get straightened out. It's going to take a while, but I mean, moving forward, maybe in sometime in my career, we'll actually see this come to fruition. So anyway, I appreciate all of your presentations. With that, any further comments, Sheila?
None for myself.
All right, well, Jessica, you're already on the screen and you are up next. So for possible action, seeking board input on Northern Behavioral Health Policy Board priorities and potential bill draft requests, Jessica Flood, soon not to be our Northern Regional Behavioral Health Care Coordinator, which I'm very sad about. So go ahead, Jessica.
Thank you, Dr. Titus. Yeah, and for the record, Jessica Flood-Abris and Dr. Titus and both Shayla Holmes are on the Northern Regional Behavioral Health Policy Board. I had a quick question for whoever just shared the screen. Can I just share a quick updated presentation that gives a view of the Northern Board's priorities really quick?
No,
Okay.
I'm just kidding.
Oh, I was like, I'll just go through it, but we have a couple of priorities, so it might be helpful for people to follow. Okay, great. So I'm just, here we go. Okay, so this is an update on the Northern Regional Behavioral Health Policy Board. For those of you that are not aware, Nevada is trying to regionalize their behavioral health efforts with 5 regions. So there's Washoe County, Clark County, there's the rural region and the southern region, and then our northern region is Carson, Lyon, Douglas, Churchill, and Story counties. So I'm just going to put this on screen share. All right, so the northern region's priorities, just for a quick overview, and I'm going to jump into this top one more as we move forward. But the first priority is regional behavioral board infrastructure development. The northern region, I think, has been one of the most proactive and long-standing regional behavioral health efforts. I came in 2015, and leaders in the region, such as Jeff Page and Dave Fogerson, have been meeting since 2013. So there's really quite a bit of cohesion with this regional identity. And as you guys know, that really aligns also with the Quad Counties. So the board is interested in kind of developing more infrastructure to support data analysis and coordination, and we'll talk more about that. The next priority is for affordable and supported housing and other determinants of health. There's been a lot of focus on crisis response, but there's a greater acknowledgement, not just in Nevada, but also nationally, that really a lot of people that are in crisis, they need their basic needs met in order to get out of crisis. And housing is one of the top pieces of those basic needs. So as you know, if someone's suicidal because they're homeless, they end up in the hospital gives them medication, they discharge, they're still homeless. You still have someone who's in crisis. So the northern region was looking at that. Behavioral health workforce with the capability to treat both adults and youth. I think when I hear, especially in the rurals, but statewide, workforce is probably one of the top priorities, especially with behavioral health that's really hampering our efforts in moving forward. The northern region has actually been pretty successful in developing their own local crisis response system that has, like we said, the most fast crisis intervention training and Mallory Crisis Center. So the board has been really focused on making sure that those have sustainable funding sources on them. Mallory Crisis Center now will be able to fund through Medicaid with a sustainable rate. So that's exciting. And we do have some tentative plans, hopefully in the works for Most and Fast as more funding comes in. We're also looking at increasing access to treatment in all levels of care. You can see that there's definitely progress by community providers, especially in Lyon County, but just really making sure that it's not just outpatient and inpatient, but that we have those levels of care in between. And then finally, developing services to support continuity of care. And the community health worker initiative has really been a large piece, not just of workforce solutions, but also in making sure that people get to the care that they need. Are there any questions on priorities? Okay, and then just really quickly, the 2 subcommittees that the board has had is supportive housing, like I spoke about, and then also the Regional Behavioral Health Authority, and that's what I'm really going to focus on today. So the idea of the Regional Behavioral Health Authority actually comes from the 1950s. Individuals back then from like kind of the 1800s were hospitalized in institutions for years and sometimes decades. And around the 1950s, there was this push to really deinstitutionalize, have those individuals with serious mental illness be supported in the community with community care. So in 1963, the Community Mental Health Centers Act was passed, and it really said that unless people are a danger to self or others, that they deserve to live in the community. In response to that, all states developed involuntary treatment laws. Our region has really focused on that. That's NRS 433A. And then all states, I believe, or most states, created local mental health authority laws. And that was the whole point of that, was that the state was running these hospitals and they were going to transfer funding down to the local communities so that they could really take care of their own mental health systems. Through that, most states ceased to serve as the primary provider of behavioral health services for people without insurance. So my chair, Taylor Allison, the chair of the Regional Behavioral Health Policy Board for the North, she and I went through all 50 states looking at the different models to, how you manage behavioral health. And there are some states that have only state authorities. It seems like the states that are successful with that have just very robust healthcare systems that can be privatized. And then you have states that have kind of this either local or regional infrastructure. And the thought behind that is that, especially in states like Nevada, where there's a pretty thin administrative lining at the very top, you really create some middle management to be able to make sure that you're responding to the needs of the communities. So one of the issues is Nevada actually has this in law in NRS 433C. The issues that were created by this lack of local or regional behavioral health authorities, even though we have it in law, we never actually developed it, is, like I said, the state has a pretty thin administrative layer. And because of that, they are not always able to fully manage the behavioral health resources across the state. A good example is SAPTA, which is the behavioral health funding arm. They manage like 150 grants and they have no idea really what's happening on the ground. If providers are fulfilling their grants, if they're duplicating services, et cetera. And so that brings an issue of lack of coordination, lack of accountability, and then it also inhibits data-driven decision-making. So how this was brought up is that as we were talking about 988 and the crisis response system in the state, there's this national document called Roadmap to an Ideal Crisis System that recommends that you have an accountable entity that would be able to coordinate the community crisis services. So just like you said, Dr. Titus, that there's all of these lines, all of these services, and then you've got, crisis support services providing 988. How do you really make sure that at the local level, you're addressing the needs of the public and making sure that people are getting the services that they need? So that accountable entity actually gets funding subgranted from the state to the region, and then they coordinate the services at the regional level. In the Arizona model, they actually oversee the Medicaid for people with serious mental illness. But in other states, we see that the regional behavioral health authorities oversee crisis services. And they also oversee mental health block and substance use block grant funding. And court-ordered evaluation, which I don't think is like a topic in our state, but I know that that is something that the local communities are now needing to take responsibility for as well. So in NRS 433C, it allows for county commissioners to establish a county community mental health program. It establishes a governing board and duties. Basically, the county commissioners opt in, and then the way the current structure is that you would appoint people to a board, a governing board, delineates direct services that could be provided by the program, And then it also allows for joint efforts by multiple counties. And in the current law, it says that the state would give the county 90% and the county would provide 10%. We realize that that's probably why it never happened, that the counties don't have much funding for that behavioral health piece. So the Northern Board is exploring the concept of potentially having this as their legislative bill draft and just updating it. And this is all enabling language. It's really focused kind of like on the public health district side for counties that are really interested in taking over some of those oversight of the services for accountability. So we bring this up now because obviously public health is a very hot topic right now, and behavioral health could be taken into account while those public health systems are developed. So the decision points that would be looked at just statewide if this law was updated is just, how to modernize that law, making the regional behavioral health policy board an advisory board potentially. And that was the thought actually with these behavioral health policy boards, is that 5-7 years ago, they were looking at trying to regionalize and create these kind of regional authorities. And that was too big of a step. So they created these boards, which are great for advocacy, but in terms of really getting some local coordination and control over behavioral health services, this would be the next step. Then also delineating the duties and the scope of the authority. And then the big one is looking at the funding and reimbursement mechanism for the authorities. So I know this is a huge concept, but I thought it was important for you guys to be aware that the board is kind of tentatively exploring what this could look like. So these are some of the benefits that could happen from behavioral health authorities, that you'd have more centralized coordination and accountability. It allows for increased community oversight. We see this in a lot of our rurals where providers come, they get funding, and you're not actually seeing a lot of the services that they say they're going to deliver. Increase oversight of the funding decision. So being able to say, hey, this is a great example that the Board of Health says, oh, we have an issue with youth, and really making sure that the funding is going towards the pieces that matter to you. Opportunity for service development. So really looking at being able to develop services in a specified way that's unique to the region. Quality improvement. So a lot of behavioral health authorities across the nation will identify like, oh, in this region, we need more providers that are trained in youth behavioral health. And then they can facilitate that training, make sure that they get it. Enhanced local response. So we've actually seen this with the youth mental health crisis. I definitely saw this, especially in Washoe and Clark counties, even in these huge counties. When they had the crisis, they went to the state and said, hey, what are you going to do about this? And as you all know, the state, especially Dr. Tice, the state can only move so fast, especially with legislature. And so being able to be a little more nimble at the local level. Increased capacity for the mental health system management. Again, there's a real bottleneck at the state in terms of flowing grants, et cetera. And so looking at being able to have a sub-grant that allows the regional level to coordinate that. And then also, I think one of the biggest factors is that the state leaves a lot of funding on the table for federal grants. And it's just because they don't have the capacity to manage them. And so at a regional level, if we were able to create more of a regional framework, we would be able to apply for grants and bring more funding into the region. And that's what we have on the concept so far. The subcommittee has met twice or once. The last one was last week, and we're looking at a June meeting as well. Are there any thoughts or questions?
So thank you, Jessica. Is there anybody have any questions for Jessica? So one of the things that she did point out is these grants that are left on the table that we need to be aware of, and also the advantage that at the local level of moving quickly when we see crises. And it's an understatement, Jessica, to say that the state moves pretty slow. just, meeting every other session, getting them passed, getting them implemented, and all of those things. So we're usually behind on that. And so again, it's best to start as local as possible because you can be quicker. So thank you for all of that. Anybody questions, observations, comments? I see Jeff, you are at the podium. What would you have to say?
Madam Chair, Jeff Page, County Manager for the record. So in listening to the variety of presentations thus far, and then Jessica and her situation, I think it's very apparent, as you stated earlier, that we have a number of silos that exist out there. And what Jessica does with her board is just another silo that not everybody in the region or the county understands what we're doing with behavioral health, what needs to be done with behavioral health. So I think from the perspective of Lyon County, a couple of things we need to focus on is do we want to begin looking at controlling our own destiny, or are we going to continue to rely upon the state to provide services? And I'm not here to bag on state health. They do a phenomenal job with the resources they have, but they are worse than any other employer I know as far as turnover. I have 2 children, as an example, who are special needs or adult children now. I've had 37 caseworkers for 1 child in 6 years. So that's my concern, is that maybe the next Board of Health discussion, we will have a discussion about what is it Lyon County wants to do and start narrowing some of this down. There have been discussions in the past. 15 years ago, there was legislation to take a look at creating a quad county health district. The challenge with that today is that everybody's capped out on tax rate, so there's no way to fund it. But there are some things I think behavioral health has become the big issue. And I can tell you that just my own personal perspective, looking at our health rankings as a county, it's more than just not having enough doctors. It's more than just getting people to stop smoking or eating correctly. You have to look around our community holistically and see we have a bunch of junk that people have built up in their properties that cause people problems. We have significant homeless issues now that we never had before. So I think the Board of Health, and I realize we have one more presentation to go, but we may want to consider in a future Board of Health meeting, maybe a workshop on what local control would look like and how we would eventually get there to deal with some of these issues. Because the state's answer is, here's a cookie cutter approach to fix the problem. That cookie cutter approach does not work within Lyon County. In South Lyon County, where I have a significantly older population, community health has different needs than in Dayton, Fernley, Silver Springs, where I have a younger population who have different needs. But the state's answer is, we do this in our community health. That's just an example. The same thing with the mental health issues. There are not enough providers. And no disrespect to the state, but the amount of money they pay licensed clinical social workers or psychologists compared to the private sector, compared to larger counties like Washoe or Clark, we're always going to be behind that 8 ball. So maybe it's time for us to have that hard discussion in the future about, do we want to take control of our own destiny?
Thank you. Thank you, Jeff. Any other comments? All right, we'll move on to our last agenda item, 6E, for possible action, presentation on opioid litigation, funding, needs assessment, and options, seeking board input and preparation for the BOCC allocation of funds. Shayla Holmes, you're back up.
Hello, Shayla Holmes, Director, Lyon County Human Services. I wanted to take this opportunity with the Board of Health to share what the current conversations are regarding the opioid litigation, some different funding streams, and then what my recommendations would be for us to have a sustainable future without this funding. So I want to start with what creates opioid use and how we end up to this point in time. And it's, utilizing opioids, whether it's illicit or licit use, is just the tip of the iceberg. How we get there is a variety of different things. So it's going to require a variety of different responses to really address the full issue. Pain management's like the number one. That's the highest piece, is that we've resulted to opioids and overprescribing and things that were once considered the best option we're now finding was not the best option. Other things such as trauma and unhealthy coping mechanisms and the variety of different reasons why folks turn to substance use and misuse. And in general, individual and community-wide beliefs around opioids, whether we have an opioid issue, whether it's something we even need to be addressing or what that looks like. So all of these things together create what opioid use is in Lyon County. And it's going to take addressing each of these things to really be able to get a handle on how we prevent opioid misuse going forward. So the process for the opioid litigation at this point in time, there is 2 separate buckets of money that are going to be available to us. The state funding that's going to be coming out is expected to be through grants, and that is anticipated to be open in July. What we know about that funding is that they're requiring agencies to have a local needs assessment. Yet another one. So we'll be tapping on Carson Tahoe's needs assessment and all the other ones that are being produced. At this point in time, with the existing data, Lyon County Human Services has a draft needs assessment. We utilized all of the existing data sets available both locally and regionally, and it is a lot of information, probably too much. I mean, really, when you look at all these different data sets and all the different folks that collect it, and trying to find some commonalities throughout it, but we do have a draft at this point in time utilizing the template provided by the state to be prepared for these funds. What we did utilize was our stakeholder and community member feedback from our opioid summit workshop that we conducted back in 2019. Our opioid issue hasn't really changed since 2019. Here in 2022, the pandemic really highlighted the use of it. And unfortunately, really recently, we've experienced some more of our youth being involved with fentanyl and some illegal pill mills and things of that nature. So we're starting to see more and more of it, but the feedback and the information that we obtained during that workshop still remains the same and still very relevant. We also know within the state funding, aside from having to have this needs assessment, that the programming will be able to write for in regards to what they're going to be willing to fund is going to be evidence-based programming and services that are presented from the ACERN and surge groups. So the funding from the state is going to be very limited and stricter in regards to what's available for us to draw into our communities. I think we're going to be able to utilize it, don't get me wrong, but it's going to take more. Grant management's always a beast, and it's going to be very specific in what it's able to be utilized for. The county allocations, while this is still not defined or, it's not issued at this point in time as far as how much and when, and I know that at this point in time there's only been one settlement and there's still litigation pending, so the amounts are not finite. I believe Mr. Foley presented to you guys at the last Board of Commissioners meeting in regards to it's going to be a lump sum and then sums after that in a lower amount over a period of time. They did offer, the litigation offered a opioid remediation use document. It's about 30 to 40 pages listing all of the things that you could utilize it for. And the final amounts are not available yet. But we do know that the county allocation is going to be looser. We aren't going to have to present, we should base it off of a needs assessment, but it's not going to be as strict as the evidence-based programming and the grant requirements that are going to be required through the state. So right now, our needs assessment findings from what's in draft with the preliminary data, of course, everybody's in the middle of doing their needs assessments and updating that. So the needs assessments and the data that we're pulling from is all from about 2018, 2019. And then so we utilized the regional available data and then data available within the department. And some things that I just want to highlight. So our senior population is the highest rate of most utilizers. The highest, 200, I think, calls were in response to seniors, with adults being far less in the hundreds. I think a high 90s. Our seniors also have the highest use of prescriptions, and they also have a huge gap in services available from community-based to long-term care. Our youth has no local crisis response team. So we did hear Michelle talk earlier about the mobile crisis response in regards to youth from the state. They right now within Lyon County will respond telephonically or telehealth. They will not respond in person at this point in time because of staffing issues, the ability to actually do it. So we have no local physical response team right now for youth. We are starting to see fentanyl overdoses within our youth. And we do have a lack of programs and services to positively engage youth and to steer them away from substance use as a coping mechanism. I also want to touch on the system of care program that we recently implemented in partnership with Juvenile Probation and Community Chest has quickly, within the first 6 months, exceeded its current capacity. So we know that there are high behavioral health concerns within our youth. And we also know that co-occurring substance use and mental health go hand in hand, because what individuals typically get a hold of to help with their mental health sometimes turns into inappropriate substance use. Our harm reduction. So as a outcome of the HRSA Resilient 8 grant that Lyon County Human Services currently receives funding for, which is also going away, unfortunately, most of those federal grants are capped, and I think it was at a 3 or 4 year cap, and it's coming to its end. We will continue to do naloxone distribution. We'll just no longer receive funding to do it. But what we saw after implementing that from our 2019 opioid use workshop is that we've nearly doubled in 2022, and it's not even done yet this year. And this is calendar year numbers because it was easier for me to pull. In calendar year 20, when we started, we issued 20 naloxone kits. Calendar year 21, 30. Calendar year 22, and we're only in May, I've distributed 75 naloxone kits through our offices, which is pretty significant when you consider the numbers over the years. It's great. Naloxone is a great preventative measure, but that also shows a greater need within the community to have naloxone available. Our Urington office, it also isn't able to have that on-demand naloxone response because we don't have it staffed full time, and it's something that we're really working to do. They have it there. I just don't always have a staff member there to give it out. As far as prevention, we need system-wide education campaigns. So this is something that's been seen in our needs assessment findings, and something that every time we get a group of providers together, this is what comes up. At our most recent Stepping Up Youth Initiative workshop, system-wide education campaigns in regards to how we educate parents, how we educate youth, how we educate seniors. There's different education needs for the community across the lifespan, but it's certainly something we're lacking. And then lower level intervention. One thing that came out of our opioid workshop, and then also continues to be highlighted, is the need to have universal screening and evidence-based programs across all of our different providers. That universal screening, that no matter where you go to, whether it be a food bank, a human services office, a mental health provider, walk into the doctor's office, universal screening for substance use issues, behavioral health issues is what we need to be able to get to the root cause earlier on and target really what the issue is with individuals from the beginning. So my recommendation for Lyon County in regards to how we can utilize our county allocation is for us to start stepping into Medicaid billing. And the reason being is that we talk a lot about sustainability of our programs. We talk a lot about how we can utilize money available to the county in situations like this, where we have such like ARPA money or opioid money that's coming in, and how we can utilize that to ensure that we continue to bring in more money. And if we could get into Medicaid billing, we can ensure that any program that we enact through opioid funding can sustain and be present past the allocations coming. So opioid money, much like the tobacco funds, much like the alcohol dollars, all of those things are limited and finite and will have an end. And opioid litigation money will have an end to it. It's not going to stick around forever. It might be for many years, it might be for less. We're not really sure on that at this point in time, but I do believe that if we were to invest in, at a minimum, having a Medicaid biller in a database for staff to be able to put in Medicaid notes and assign those Medicaid services, that at a minimum under provider type 54, that Lyon County Human Services would be able to set up a reimbursement process that's not grant dependent and not dependent upon county general fund, to ensure we continue to do case management, which includes things like our system of care, which we've seen exceed our expectations, unfortunately, for our youth. But we could serve youth with diagnosis not meeting SED, so severely emotionally disturbed threshold, and adults with a diagnosis not meeting severely mentally ill threshold. And then we could also aid our juvenile probation department in Medicaid billing for their targeted case management as well. And all of these dollars being able to be put back into these programs to ensure we can bring on behavioral health supports going forward. So if the funding is enough, and it was what was bought into, a Medicaid biller plus a database. So a provider type 54 we could be right now. We just aren't, because we don't have the ability to do Medicaid billing, lacking the biller and lacking that capacity. But that utilizing these funds to invest in that could get us into being a provider type 54 right now, and creating that sustainability for services already offered, and then creating funds to be able to expand. if we were able to get a Medicaid biller and a database plus a clinical director, we could become a provider type 54. And I don't see what my little specialty is. Oh, provider type 54 and provider type 14. So we could be both provider types, which adds our ability to start Medicaid billing for our crisis response teams. So our MOST team could be sustainable. Our MOST team could be sustainable and potentially grow to serve youth and seniors. We'd be able to do our own in-house screening and assessments to ensure we're able to create treatment plans and get folks referred out and connected to long-term therapies faster. We'd be able to do that screening and assessment and potential therapy for juvenile probation, which is a huge need for them as they continue to expand most of their budgets on trying to address behavioral health for youth. Basic skills training within our adult services division and even within our senior services division could become reimbursable. And then we could also expand into peer services, as most of our staff are community health workers. They could also start working into that peer realm. So what that means is funding and structure for long-term sustainability of existing programs, and also the potential to be able to have sustainable funding going forward for future expansion of those programs, such as FAST, MOST, and System of Care and other services throughout the department. So that would be my recommendation as far as county allocation goes, for us to be able to ensure that what we're doing now stays, and then to be able to utilize the state grant planning and utilize the state grant funding for things that are evidence-based and things that the state is willing to pay for based off of what they're coming up with their needs assessment and the ACRN and search group. So this is not by any means extensive, but this is a starting list of what's been identified from our needs assessment and what has been talked about as potentially being fundable through the state in regards to the naloxone distribution, MAT services in the jail, getting into screening, brief screening and intervention and referral to treatment, which is also Medicaid billable, but getting that throughout the entire county and different providers so we can get to that universal screening piece that was mentioned. We'd be able to potentially increase holistic pain management and health classes within the schools, increase the availability of clinical workers available within the school district. I know they have clinical support to some schools within the school district, but not throughout. And that was a need that was identified within the Youth Stepping Up initiative. And then as far as recovery goes, being able to utilize the MOST teams for post-overdose response. I know that is something that they're talking about at a state level, being able to increase workforce as far as peers with tied to some of our programs. And then creating supportive housing. There's a lot of funding available right now within supportive housing, and this opioid funding might also be available for that. And that is certainly a big need within our county as far as where folks go when they are in recovery and how we keep them in recovery. So the allowable uses for the funding is large and wide and broad. And it, like I said, it's about a 40-page document, but these are the highlights. Then there's a variety of different things that fall within these, but naloxone distribution, medication assisted treatment, pregnant and postpartum women as a target population, and a variety of different things within there. Expanding treatment for neonatal abstinence syndrome, expansion of warm handoff programs and recovery services, treatment for incarcerated individuals, prevention programs, and expanding syringe service programs. And that is where we're at right now with opioid litigation, available or funding uses, and my recommendation. And I am certainly open to input, thoughts, and what we can do to make sure that we're prepared when this funding comes out, that we're able to utilize it in the way that you guys identify best for the county.
Well, that was a lot. Thank you, Shayla. Lot of, I think, forward thinking that you're doing there. So thank you for that. Are there any questions, board members for Shayla? I have some, if nobody else does. So question regarding naloxone. You have given out or dispensed 20 in 2020, 30 in 2021, and 75 in 2022. Do you know how many of those were actually administered?
That I did not pull that data. I can ask CSAT for that. So we get it for free from CSAT, and for getting it for free, we do their survey and send that survey in. So I can ask her to pull those numbers, because they would mark that on the survey if it was a a refill? And if it was a refill, what was the purpose of the refill as far as being administered, expired, or another reason?
Right, I'd really like to see that kind of data on how much is being utilized, but it is good to know that people are actually having it in their possession. So I think that's one of the early keys. We did try to get a bill to have it allowed along with the EpiPens in the schools, but we still have a ways to go with that. You said it's not being given out during in Yerington as much because of the staffing issues. You're just not open. Is there some other communication that can happen so that folks, you don't want to administer it when somebody has, I mean, you don't want to give it out when there's a need, you have to come get it, et cetera, as opposed to, you have it in your possession when you do need to administer it. So do you have some other ways to let folks know you have it so they can have that, you can hand that out, et cetera, in Yerington here, when you're, it shouldn't be when you're just having it when you're open, and those hours should help because again, they don't need it at that moment. If they need it at the moment and they don't have it, it's too late is my point. Are you working on that?
Well, we are working to get, as far as the preventative education piece, yes. So consistently doing education, particularly one-on-one with clients as they're coming in, doing that universal screening and identifying folks that might need it early on and making sure they get it when they're there, as opposed to that crisis response piece. We have had individuals call us because we've got a lobby phone, we've got the health nurse there. So when folks call and say, I really need naloxone, and do you need 911? Because if you really need naloxone right now, you probably actually just really need 911.
Exactly.
But for folks that are planning perhaps to have an evening of opioid use or whatever that their future plans are, and they're coming to get it for us for preventative need. We have partners in Yerington like Rural Nevada Counseling, and we also have CCI that can aid us with if they've got naloxone on hand. I know that we're one of the major distributors of naloxone, but I do know Rural Nevada Counseling has it on hand. And then the pharmacies also have it, but if you don't have a prescription, it's really costly. So most people aren't generally willing to go that route. But absolutely, we're working on identifying folks that would need it the first time we meet them and getting it to them the first time we meet them, as opposed to them needing to come back, because it never hurts to have it. I mean, no harm and doesn't cost anything.
Great. And Sheriff, do your deputies carry naloxone?
Yes, we do. We've got it. Shayla has been kind enough to provide us with it too. So, we've actually had, I don't know the exact numbers, but 4 or 5 instances this year that we've actually had to dispense it. I mean, side thought here, I know nobody wants to come to the sheriff's office to pick up their naloxone, but we got somebody there all the time. So, so I don't know if that can be an option or not, but.
And then the other thought that we're, if we were to go the route of a Medicaid biller, the location we would want to put them would be here in Yerington. So we would have somebody in that office Monday through Friday, 8 to 5, and they'd be able to help with dispensing that as well.
And that was going to be my next question. And the Medicaid biller, you already have a kind of a clinical director, do you not? Do you have, so you for personnel purposes, you need a clinical director, and then you need the Medicaid biller. And I'm just wondering if you've run the numbers on, does it pay ultimately going that route? Just because the Medicaid reimbursement is delayed. Number 2, what you get back from Medicaid billing is somewhat limited. And number 3, the cost of getting that your provider and then the biller when there's limited resources. So have you looked into what the economics of that is?
Yeah, I've met with Medicaid a couple times and walked through the reimbursement rates. So the delay, yes, and that is an issue for sure as far as when you're a private practice and how you're able to utilize that, which is why we would really like to be able to utilize funding like this to get it started, to prove its sustainability. And that way the delay doesn't impact our ability to maintain in the beginning, at which point then we can maintain going going onward. The current Medicaid reimbursement rate, and the county would be available for increased allocation due to us being a government agency. So I'm not sure what that amount would increase our hourly rate to, but for our bachelor's level case managers, it would reimburse at a rate of $24 an hour, which covers the majority of my staff costs minus their fringe. So we would still be grant reliant, but not as heavily grant reliant. And it would allow us for that ability to not have to lose staff during grant turnover while we're continuing to seek those funds.
Okay, thank you for that. Because I am concerned about the cost of expanding programs that then we can't sustain by our billing with the state, and at the county ultimately is left holding that versus the services that we already have. So would love to see some more numbers, and I'm sure the county commissioners on this call would like to see that too when they are looking at their budgeting and personnel costs, et cetera. So any other questions from our board members? Okay. All right. Well, thank you. And thank you, Shane. Commissioner Gray.
Yeah, I do have one. Aren't there private companies that we could contract with to do that instead of adding more staff?
In theory, yes, we could certainly look at that in regards to cost effectiveness and what that would look like. I think a benefit to bringing it in-house is that we also then have additional staff in Yerington to make that office full-time, to be able to provide some of those as needed services such as naloxone distribution. But I think looking into what the cost of a contractor is absolutely, I think, a viable option.
Yep. And that also brings me to my next question is why Yerington? I mean, wouldn't it make more sense to have naloxone distribution centralized in, say, Silver Springs out of your office there? I would venture to say that the opioid use in the Central Line corridor is higher than it is in Yerington.
I'm not too sure as far as, so I do know that Lyon County was the third highest overdose rate in 2020. Which part of the county those came from, I'm not too sure. I'll have to see if I can get some more targeted data on that. The best approach for naloxone is to have it available where the individuals are. So we distribute naloxone throughout all of our offices and senior centers. So Dayton, Fernley, Silver Springs, and Yerington. And we really see the highest amount being distributed in Fernley, with the second highest being Silver Springs, and then Yerington and Dayton. But having it available where the folks are is by far the best approach, because getting from Yerington to Silver Springs to pick up naloxone is probably not your highest priority if you're an illicit user. Licit users who utilize the prescription mechanism absolutely could travel out and most likely have the means to be able to do that. And but I think our illicit population is the one that's less likely to travel for it if needed.
Again, though, why Yerington?
Because Yerington does have an opioid misuse problem. It is an issue everywhere. And so having it throughout the county is important. We don't just have it in Yerington, we have it in all locations. Yerington's just the only location right now with a gap of services in regards to not having the office staff full time.
Okay, that answered there then. Thank you.
Thank you for the question. Any other questions? All right, thank you. Well, again, thanks for the effort. Thanks for thinking about solutions and not just adding more issues. So again, thank you. All right, with that, that ends our formal presentations. Are there any board comments? Seeing. Thank you. So we'll go to public participation. There's nobody in the room, but is there anybody on the call that would like to have a moment of public participation? Oh, I'm sorry, I didn't see that. Go ahead. Commissioner Keller?
Oh, sorry about that. I didn't hear you. And Jeff, I think your mic's off because I could barely hear you as well.
I do that on purpose.
Yeah, well, it's kind of tough for us that are on Zoom. Anyways, no, I just wanted to make one comment to thank everybody that presented today. A lot of great information, a lot to think about, especially, you know, when it comes to funding and how we're going to have the sustainability moving forward. So I just wanted to, like I said, I've been kind of quiet today, but listening intently and wanted to let everybody know that I appreciate the presentations.
Thank you for that. Any other comments? Again, we'll go back to any public participation. I don't see any hands. And if someone is on the line that wants to add a public comment, just unmute yourself and let us know you're there. Hearing and seeing none, I will take a motion to adjourn.
Madam Chair, you don't need a motion.
All right, then we're adjourned. Thank you, sir.